Happy March.
Okay.
Got it. Got it. Cool. Oh, we're going next time on Zoom too.
Yeah, June 1st, and we may be going live. We'll let everybody know.
Wow.
Yeah, the West Palm Beach Community Room is scheduled to open up, what, in April?
She said to check back in April, possibly May.
So June 1st.
Could be
Well,
us.
That'd be cool.
God willing, when the and the mutations don't forestall, we'll be going live in June.
That'd be very nice.
Combination of Zoom and live.
If the technology at the police department allows
Yeah,
it.
check into that because there are people out of the county that probably would be more convenient, especially from Tallahassee.
Definitely.
Yeah, wow.
We have the technology now.
Is anybody having trouble with their cell phones?
Yes, today, yes.
Yeah, the last couple of days, it's like the Russians have, have kind of.
I can't believe that's
Make
exactly what I thought.
Okay.
It's so weird you said that because it was buzzing and there was something going on and I was convinced we were being spied on.
Well, I'm just having reception problems.
Yeah, that's what I'm having too, with buzzy noises.
All right, we're in double digits, but we'd like to have at least 20 or 30 people on before we start. And it's one, so a couple of minutes before. This meeting will be a little shorter than ordinarily. Well, of course, I say that all the time, but I've had two presenters that had to cancel out because of emergencies. So
Oh.
I think we're gonna be out of here in a couple of hours, hopefully, maybe even less.
Audio.
Can you, the audio, and I've got this up
The
all the
volume,
way.
yeah, you can increase the volume
It's
here.
all the way up.
It is all the way up?
Yeah.
Oops, sorry.
Well, Paul's become nicer.
Yeah.
I don't know why.
Should help this. Well, let's put it back in the other one.
Well,
So this- okay. All right.
thank you. All right, we're up to 27. Let's go ahead and get started. Okay, first I'm going to, I don't call it a roll really, but members, I've got First Department of Health, Dr. Alonso, are you with us?
No, she's not coming.
Is anybody from DOH here? Okay, DOH is not here, so we can say things about them. I'm just kidding. Dr. Andrick, Dr. Belma Andrick, are you with us? I think she'll be tuning in. I know they're very busy over there at the healthcare district. Dr. Atenito, Jennifer, are you with us?
I am here.
Great. Hi, Jennifer.
Hi.
With FAU College of Business Health Administration. Tom Baird, attorney, Joseph Foster. Tom, you with us? Okay, Turner, I saw you were with us. Turner Benoit with Hanley.
Hi, guys.
Hey, how's it going, Turner?
Good.
Ariana Ciancio, I saw you were on as well. Ariana with Delray Beach Police Department.
I'm here.
Well, your
I'm here.
title is advocate?
Service population advocate.
Service population advocate. They're lucky to have you, that's for sure. Is
Thank
Darcy,
you.
you're welcome. Is Darcy Davis with us, Mr. District? Okay. Steve Farnsworth, FAR.
Yep, I'm here, and so is Whitney and Heidi.
I saw Whitney and Heidi were on as well. Thank you so much. Suzette
He was like,
Fleischman. from-
Whitney, what do you think about blah, blah, blah? And I was like, oh shit, is that me? And I was like, oh, it's different.
Okay, mute thyself. Suzette Fleischman, DCF, DCF, you with us, Suzette? Okay, who's with us from DCF today? Nicole?
Can you hear me?
Yeah, barely.
Sorry, yes, Nicole Moran, DCF.
Okay, thank you, Nicole.
Also Jennifer Williams, overdose prevention coordinator for the Office of Substance Abuse and Mental Health Services with DCF as well.
Yes, Jennifer, I was going to introduce you. I believe this is your first meeting. And as the overdose prevention specialist, I think we have a lot to collaborate on, and I do look forward to working with you. So welcome, Jennifer, welcome.
Thank you. I appreciate that. I'm glad to be here.
Uta Gaziak? Uta,
Good afternoon, everyone. I'm
hi,
here.
how you doing?
Good. How are you, Al?
How's Tallahassee? Are you recovering from the last session?
Not quite yet, but I'm sure by Friday I'll be okay.
Well, we had some success, but we have a bone to pick with the Republicans in the House. So
Well, good luck with that.
well, I don't
Our
expect.
budget did pretty well, so I'm not going to complain too much.
Yeah, we're going to have Ann Berner talking about that, but you know, in all seriousness, we will be talking about the fentanyl test strip
I know.
failure, which should not have happened, and we will be working the next 12 months so that it doesn't happen again. Lori Hunt, Lori Holslaw Hunt, are you with us from Oxford House?
Hi, I'm here, Al.
Hi, Lori. We'll get an update from you. Anybody else from Oxford? I saw somebody else on.
Yes, we have, I believe, Chandra Brown, Elizabeth Lewis, and Tyler Sykes.
Hello.
Okay, you're well represented. I look forward to hearing the progress in the last 2 months. John Hewlick, Palm Beach County Community Services.
Hi, Al. Good afternoon. John Hewlick here.
Yeah, I will all say in parentheses, the Palm Beach County Drug Czar. Welcome, John. I know Jeffrey Lynn, he's a zoning attorney and healthcare law attorney, and he's not with us today. Okay, Neil McGarry. Neil, from the Florida Certification Board, are you with us? Neil? Okay, hopefully he'll be tuning in. Now we have Melissa McKinley, but is Joseph, are you there? Joseph Sophie?
Yes, good afternoon, Al. Good afternoon, everyone else.
Good afternoon. Thank you, Joseph. Thank you for tuning in. Dr. Robert Moran, Medical Director, Family Center for Recovery. Dr.
Hi,
Moran.
Al, I'm here.
Hi, Doc. And
Hi, Al.
Tom Baird, you've tuned in. Okay, great. Welcome.
Yes, sir.
Jones and Foster attorney. Okay, Dr. Rachel Needle. Rachel, are you with us?
I'm here. Hi.
Always a pleasure. Thanks for tuning in. Terrell Pyburn, I believe she has a conflict. She's a Coconut Creek City attorney and the one of the mentors behind the recovery housing ordinances in some of the local municipalities. But anyway, Susan Ramsey, I saw you're on. Susan Ramsey, attorney at law.
That's
Terry-
why I read all the books.
Terry Shapiro, are you with us? From Hanley? I guess Turner, you're representing, and I guess Terry's not with us today. Okay. Nikki Soda, I think she's tuning in, but she's on vacation. Nikki, are you with us from NAATP? Okay. Alton Taylor, I saw you were on, Alton
Here.
with the Drug Abuse Foundation.
Here.
Okay, great. Dr. Vinacore, Lori Vinacore, Alliance of Delray Residential Associations.
Here I am.
We're in there. Hi, Lori. We have an intro for Richard Warms. He's a investigations coordinator with the Office of Attorney General. So he's out of Tallahassee. Richard, you with us?
Yes, sir. I'm with you.
Hi, how's it going?
Thank you. Going well. Glad to be here.
All right, you all do well in the legislative session?
They did very well. Yes, that's the report coming out is the across the board for state law enforcement and state professional support employees. As far as financial gains, that was really important to help support everybody in the work that they do for the state. So I think they did very well.
Great to hear. And lastly, Eric Urolano. Eric, you with us? Anybody representing the Integrity Billing Company today? Well, we'll see if they tune in. Okay, I'd like to welcome everyone else who's auditing and participating, at least at the end, in the State Attorney Addiction Recovery Task Force, which was formerly known as PRINCE. No, formerly known as the Sober Homes Task Force. Let's see. Let's get cracking with some of these statistics. As I said earlier, for those of you who tuned in, our meeting is a little short today. We had a couple of presentations that had emergencies or had to cancel, and so we're going to be our meeting will be a little short. So just want to for those of you who are not at our January meeting, the Florida Medical Examiner report from FDLE came out in November. We have done some numbers crunching here at the State Attorney's Office. We've had our analysts working the actual raw data because sometimes it's very hard to determine exactly what the statistics are from that medical examiner report because they double count causes. For example, if cocaine and fentanyl are found to be jointly a cause of death, they may count both of them instead of choosing one and counting one. So we've analyzed it. So our stats that are up on this slide reflect the actual one overdose, one death. And as you can see, Palm Beach County is no longer number one. Yay. We have been for the last 5 years. Pasco Pinellas, and this is a horrible number. 688 opioid caused deaths, which is up 40% from 2019. Broward County has overtaken Palm Beach County by quite a bit. They're ahead of us. Their death rate is about not quite 10%, close to it. 662 opioid deaths, up 55% from 2019. Just go to the top of this slide. There were 6,089 opioid caused deaths in 2020, an average of 16.7 per day. And if you don't think we have a crisis, we have a crisis. That's up 42% in 1 year from 2019 in the state of Florida, 6,089. Okay, the fentanyl was present in 95% of the overdose deaths in Florida in 2020. We have a fentanyl crisis. And as we're going to discuss later on, a number of these overdose deaths, logically, and also by the statistics, it would show that a great number of these overdose deaths with fentanyl were overdoses where the decedents had no idea they were doing fentanyl. Cannabinoids, marijuana, as the only other substance in the polysubstance analysis, the drug analysis with fentanyl, means to me that the marijuana was laced with fentanyl and that caused the death. And there were 1,152 of those. Just marijuana, cannabinoids, and fentanyl. In fact, we have some legal drugs like kratom that can be bought in Florida where there are overdose deaths with kratom and fentanyl. we have a fentanyl a crisis of incredible magnitude right now that we're dealing with in the harm reduction area. Okay, District 4, Clay, Duval, and Nassau counties, 581 was up 37% from 2019. And one of the ones of note, I can't really see it because my, what did I do? Okay. What's the number for Hillsborough? Oh, I've got it right here.
13.
Hillsborough had 409 overdose caused deaths. They have a similar population as Palm Beach County, but the startling fact is they were up 88%. They had 217 in 2019. So these numbers are horrific. And it kind of gives us a guidepost as to what we need to be doing. We need to be addressing fentanyl, harm reduction, and I think in Palm Beach County, we're doing a pretty good job because we're holding the line. And I'll go to the next slide. And the next slide, we have our medical examiner always gives us early results from the analyses. Unfortunately, there's a lag to 4 to 5 months before all cases are determined. But we have 30 cases still pending from 2021 as of March 9th. And the total drug overdose cases were 628. Opioid or opiate OD deaths, 488, which is 78%. Fentanyl was present in 446 of those, which is 91%. But here's, I mean, if you can consider this good news, I mean, at least we're going in the right direction. There are 30 pending cases. We're awaiting the drug test results so that our medical examiner can do the analyses. So out of the 30, there should be, if the 78% holds up, another 23 opioid overdose deaths, which would bring our total for 2021 to 511. That's a 15% decrease over 2020. So that's significant. It's in the right direction. But you see that fentanyl is still the driver here. Fentanyl is still the driver behind these ODs. If it weren't for fentanyl, I think we would be looking at a completely different picture in Palm Beach County and the state of Florida. I do want to, we're going to get an update from Ariana Ciancio from Delray, but I do want to just mention Delray Beach. I think it's a 78,000 population. The drug overdose deaths in 2019 were 44, 2020, 63. So there's a huge spike, which there was all over the state of Florida. They're down to approximately 41 in 2021, but they're still waiting for 6 suspected cases. If it goes with the 78% model, we should have fewer than 41. We should have 40 or 39. But the 41 would be a 35% decrease over 2020, which is significant. And I'll let Ariana give you more information about that or about what's going on in Delray. Some exciting things are going on in South County, but she'll let you know during her update. Next slide. I think I can do that, right? Yeah, there we go. Okay, we have just 2 months into 2022. This is a chart that goes back to 2017 with the number of calls in January and February and the number of patients. As you can see, we have declined from January 2020 in terms of the number of calls, down from actually we've increased, I'm sorry. We've increased significantly the number of calls in January and February from January 21 and February 21, which was a significant decrease from the year before. So I don't have a reason for this. We have a total of 288 the first 2 months. It could be just an anomaly because it is just a small sample size, January, February. But we are unfortunately looking at, a 40 increase, which is 15 to 20% there. So that's not good. But anyway, just wanted to let you know, in your package, you have that comparison from the last 6 years, actually. Okay. Any questions about the statistics? Anyone? Okay, hearing none. Let's go to, actually, is Courtney, is Dr. Phillips on the call?
Yes, I am. I am,
Oh,
Al.
Okay, we want to get you in. I know you're at the addiction stabilization.
Yeah,
Okay.
I'm not, I just want to clarify, I'm at the healthcare district
Okay,
next to the addiction stabilization unit. Yes, I have a very busy waiting room, everybody. I'm covering the
Okay.
clinic today.
so let's move you up.
Yep.
Let's get an update from you for the ASU.
Okay, can I share my screen?
You may.
Please.
Okay, perfect. Let me pull that up. Okay, hold on. So let me go here. Do you guys see it in PowerPoint variety, or are you
Yes.
seeing it? Are you seeing it in the slide share? Did you see me change slides?
Slides.
Yeah, we see the
Slides,
slides on the
okay.
left-hand side.
I think I have to,
Right.
hold on, I have multiple screens. Let's go to this one. Let's try this one. There we go. See it now?
There you go,
Bigger?
that's it.
Yes.
Okay, perfect. So thank you so much, Al. That was very interesting. I just wanted to give an update from the healthcare district. We continue to track data that you guys have seen for a while, and we just presented that, I think, at the last meeting. But today I'll just give you some updates for the community. Just so that people know, we now have 8 recovery coaches, 6 hired. This is through the OD2A grant. These recovery coaches are able to sign people up for district care coverage if they don't meet criteria for Medicaid, and also serve in some ways to help patients link to the clinic. Right now, they're deployed in JFK North ASU and JFK North Hospital emergency room and throughout the hospital. The Delray Beach shower van and Delray Beach Police Department is needed with Ariana's team. We have now a nursing clinic at St. Anne's, and we have a recovery coach there identifying patients. I just saw 2 of them yesterday that were brought over. They're working with Vickers House and RIPIC, which for those of you who don't know is the high-risk OB clinic that sees high-risk mothers with addictions. And yes, we take pregnant women with addictions at this point. So we're actively taking those patients. We're working on deploying more recovery coaches to the Lord's Place. We're working on a relationship with the HUT team, but they currently come to our clinic twice a week and see patients alongside of us. So we have 2 days a week where we identify the homeless patients to have a meeting in our clinic with the HUT team. St. Mary's Emergency Department, we've had numerous meetings. They are a tenant hospital and we're trying to get somebody in there. The Drug Abuse Foundation, I had the pleasure of meeting with Alton last week with my team, and we're talking about a recovery coach in some of their new service lines so that patients who discharge from DAF or who are coming into DAF and can't be in DAF can actually get some help through the clinic. South County Mental Health we've met with, and we're working on that relationship as well. And JFK Atlantis, we did get a promise that they would have a recovery coach in their hospital. We're just waiting for it to be finalized. Transportation update. Healthcare District has a contract starting April 1st for a non-emergency transport system with vans to be able to be used if the patient is going to or originating at a Healthcare District clinic site. For those of you who don't know, there are 10 clinic sites in the county. So if they can get to one of our clinics, we can transport them to a substance use clinic. And we also continue to have the medical Uber circulation so the patient can be Ubered with some funds that we have available to give them a few rides to get started. And that's very exciting. That's starting April 1st. It's all done. There's staff hired. There's vans ready to go. So we could also transport people home and things like that. So this is a big, big, exciting new thing for us. Clinical updates, we finally are able to give out free Narcan. These are our kiosks, the picture on the right. They're going to be located at all 10 clinics. The patient can, anybody can walk up, whether they're a patient or not, and grab free Narcan from our clinics. There's going to be a kiosk in each one of the clinic buildings, and you don't have to be a patient or you can be a patient, and you can take as many as you need. So they don't even really need to interact with anybody so that there's no barriers to it. We are giving it right now in the substance use clinics for at least a month, and we've handed out over 600. to the community. We're trying to flood the community with these. I know Rebel Recovery also hands these out, but we have them. We're going to have them at all 10 of our clinics. We applied for Sublocade. For those of you who don't know, it's long-acting injectable Suboxone and it's through the FADA grant, the same grant that we get Vivitrol with. It's quite expensive, so we have to select who we use it with. We can't just give it to everybody, but it's a great tool for somebody. The good example of somebody who'd be great for this, if we can't give it to everybody, is somebody who is diverting a lot of their pills. They're having trouble staying on pills. They kind of trade them for things and they just can't be accountable with the pills. That this would be typically someone we would refer to a methadone program, but we could use Sublocade instead. It's injected into them and lasts for a month. We also had consultants come to our program from California through a program called HMA. Their Dr. Robinson, she developed the MAT programs in the County of Corrections for the state of California, as well as the California VAs. So she's brought a wealth, she's really taken a look at our program, looked at things that could be improved, things that are going well, new ideas that she has, and she's brought with it a wealth of new initiatives that we are currently working on. Location updates. We have a new Mangonia Park Clinic at JFK North that will open on June 6th. So it's in the same place, it's in the same campus, but we have a much, much larger space in the medical office building being built out, and it will have its own pharmacy. So patients won't have to walk down 45th Street to the pharmacy. We're very excited about this. And we are also opening a Delray Beach substance use program in September of 2022. So we're going to have two sites, a North Campus and a South Campus, to meet the needs of the county and really work better with the South County sites. I think that will also help Palm Beach Fire Rescue as well. Or I'm sorry, not Palm Beach Fire Rescue, the South Fire Rescues that have a hard time getting up to the clinic. Finally, we want to, I wanted to take this opportunity, and Dr. Andrick and I spoke about this, make sure that anyone in need, any provider in need calls this number 561-642-1000. They will get an appointment the same day or the next day. So you can send this out to anybody. We've improved our call tree and trained specialty staff to deal with substance use problems so that they know that this isn't something that can be booked out for months. It has to be seen that day or the next day. And we are working on an after hours program where one of the recovery coaches is actually available even in the night to help either a medical provider in an emergency room, a fire rescue somebody, anybody or a patient or their family member to get some information so they can get started once the business hours start for that day. That's all I have today for an update from the healthcare district. And I wanted to see if there's any questions.
Wow, that's a great update, Dr. Phillips.
Sure.
Anybody have any questions or comments? Hands, do you see the hands? Okay, I do have a couple of comments and questions. It's so great to hear of your collaboration with other partners like DAF and also Fire Rescue. We do have a meeting regarding transportation next week. Dr. Shepke will be on board, as well as the new fire chief. My question is the South Clinic that you're going to be opening up, is that near JFK Central? And is that something that you could perhaps partner with Fire Rescue to have transports that are at JFK Central to be handled the same way they are JFK North?
Yeah, I think that we're already taking, I mean, we do currently informally take a lot of transfers from JFK Atlantis. We have a good relationship with the endocarditis team. I just presented to their internal medicine group. So we sort of on the side, we help them. Do we have a formal addiction is JFK interested in a formal addiction stabilization unit at Atlantis? Not necessarily, but that doesn't mean their doctors aren't willing in the ER to start Suboxone. They are very much willing. And what we're seeing is that the 24-hour care from the ASU is very, very important. And people need a place to go at 11 p.m. But ultimately, it's just like any ER. The idea is to get them plugged into a long-term situation in a clinic. So what we would do is certainly take people who are from JFK Atlantis and help them transport, especially with the coach there and our own transportation. I think it would be pretty easy to have them start at any hospital and transport them to the nearest clinic at that point. JFK themselves, if they feel that they want to transport someone to their specialty ASU, they will do that internally. But I can't speak for them formally.
Okay.
So yeah, the answer is yes, but it's
Well,
yeah.
then let me follow up with this question. When your transportation is, you've enhanced your transportation, private transportation capability, is there any thought to, and the reason I bring this up is JFK Central has approximately 50% of the multiple overdoses are going to JFK. There are so many, it's such a hot spot for overdoses that we need to keep those folks from going AMA and just running off into the night. Is there any potential for having transportation from the emergency room to the South Clinic once it's up
Yes.
and running?
Yes.
Be, like a warm handoff to
Yes.
the clinic.
Yes, absolutely. And like I said, we would love to do that. Even on the medical side, we like to divert if we can from the ER during the day. So yes, the answer is yes for that. There's some new research coming out about some novel ways. A lot of people, when they take fentanyl, for example, it takes them 24 to 36 hours to be sick enough to be able to start Suboxone, which is a lot harder than heroin, which is when they typically elope, Al. But there was a new study, and I'm looking into it more. I don't want to make any official statements, but that they're trying to right after Narcaning somebody, there's a window of 2 hours. If you start Suboxone, you can actually, they've seen some success in getting them started right away within the 2-hour window after Narcan. And that has to do with some of the pharmacology of the medications and drugs. But that would be a game changer because it would allow us to get started right away and not have to have the patient suffer for 24, 36 hours to get started. So if those things kind of pan out and there's some piloting, that also would be something that could get these patients treated quickly and stabilized much quicker than they are right now.
Can you keep me in the loop on that when you find
Yeah.
out? That's incredible, since 95% of our overdoses are fentanyl.
Yeah. Yeah, and then the country's starting to there's starting to be a research base for fentanyl, actually, because it is a little bit of a different actor.
Right. I was going to talk about that at the end. The Commission on Combating, the U.S. Commission on Combating Synthetic Opioid Trafficking. They have they're keying on fentanyl because fentanyl is the driver of the epidemic.
Right.
And the harm reduction part of that, they're recommending that that there be dollars for that, and I think the ASU is perfectly situated to be. Yeah, as a matter of fact, I will say Dr. Shepke, is my understanding, is trying to replicate the ASU statewide, which would be a great thing, because for those of you who may have just tuned in today, the Addiction Stabilization Unit is partnered with JFK Hospital North, so that we have peers, we have the appropriate medical professionals at the hospital, kind of in a trauma center model. And that model is the hub, and it can spoke out through the Addiction Stabilization Unit, so that people can actually get warm handoffs and timely help. Is kind of my summation. But the upshot is we need peers. And is there any talk of having peers in the JFK Central arena, or is it just, they're going to be available for transport if they so choose?
I know the recovery coaches that we have, I can't speak, I don't know if Rebel is on this call, but the recovery coaches that we have are, yes, that's what in that update, yes, there's going to be one in there.
Oh, great. Okay.
There was sort of a verbal okay for it. We're just waiting for the official things to go through for that recovery coach. So not just transporting, but actually in there as part of the team.
Okay, keep our fingers crossed. On another note, you mentioned the homeless outreach team. Have you attempted to partner with FAR and or the Oxford House folks Because some of those homeless might be candidates. I mean, I know that there's for ancillary support, when people live in especially in a FAR certified house, they're encouraged and supported in getting employment to be able to make their way and matriculate back into society. So have you talked to either group?
So actually, Lori has actually spoken to our entire team about it. I would say almost a year ago. She did a presentation for us to understand the Oxford houses, but we could do a more formal thing. And ever since the beginning of our clinic, we've been informally working with FAR houses. Do we have a formal or so there's people going back and forth all the time. I have lots of patients who are currently in FAR houses. Do we have a formal arrangement with FAR? Not necessarily, but that's something we could talk about and what it would look like.
Okay, well, that's something behind the scenes. I don't know that you'd need one because, Steve Farnsworth and Whitney Lehman's numbers. So
Yeah.
it's not, you don't have to have an MOU with the certifying entity.
Yeah.
We did have a little meeting, not with Courtney, but with a couple other people from the healthcare district. And so we're communicating well.
Cool.
Yeah.
Awesome. And the last thing I want to ask you is you won't be on the Zoom meeting when we discuss this.
I wish I could be. I'm sorry. I got
but that's
bunch of these
okay.
patients in the waiting room today.
That's more important, but thank you for showing up for this.
Sure.
Would you at the ASU hand out fentanyl test strips if they were legal?
Yes. Yes. We need more hospitals need to test for fentanyl. Like you saw in the statistics, if you're not testing, you're not finding it.
Well,
So
the test strips,
but for
the test strips I'm talking about are the ones that would
For
identify
patients?
fentanyl in a drug. If somebody has marijuana or if
This
somebody
one?
has, I don't know.
Yes, I would.
You would.
I have it in my
okay.
office. Yep.
Yeah,
Yep,
well,
because
we're gonna work doubly hard in the next 12 months to get a carve out from drug paraphernalia for fentanyl test strips so that the consumers of drugs who
the
are
reality,
recreational users and getting cocaine or getting marijuana or getting amphetamines or Adderall, for crying out loud, can test the drug to see if there's fentanyl present.
yeah, the reality is I mean, most of my patients who are opiate users at some
Yeah.
level seek out the fentanyl because of
Right.
its potency. So you'd have to reach a population that actually isn't trying to take fentanyl and accidentally getting it. So
Right.
I don't know how you reach those people who come to South Florida for a little bump and they really don't want to use fentanyl and they just want to do some cocaine. I'm not sure how you would distribute that. That would be, I
Oh.
think, a discussion for the group to think about because that's a different group of patients, right? I think you're referring that you read about those West Point guys who came down and
Yeah.
and
That
yeah,
happened.
so
That happened as the house was stripping
but
the
if
measure out of
if
the
you could
dealer.
kind of flood Palm Beach County with them, maybe they'd get so available that people would just have them all over the place. Maybe that would be something we're thinking about.
Here was our thought process: get them into every Walgreens, and CVS, and Publix
Yeah,
in the county, in the state.
that makes
really.
sense.
But that's a battle for another day. Dr. Phillips, are there any last minute questions for Dr. Phillips before we let her get back to her patients? Okay, thank you so much.
Thank you guys so much for all you do. I wish I could hear it. And this is an amazing group. Thank you. All right.
Okay, let's move on to FAR. Steve, you're going to give us an update on statewide data and trends and MAT availability. All right, somebody needs to
Sorry, I
mute
couldn't
this.
find my mute button there.
Yes, there you go.
Okay. So are you, am I sharing my screen or is she sharing the report or do we even need to?
You can share your screen, Steve.
Yeah, you can share your screen, Steve.
Okay. Okay, this is the report that I sent in. Can you guys see it okay?
Yes.
Okay. All right. So right now, currently, we have 107 providers certified. I guess maybe I should start out by letting people know that might not know what we do as far as the state selected credentialing body for recovery residences that deal with substance use. We assess and certify on 4 different levels to a national standard of best practices. And the report that I submitted that will be in the attachments of the email that Marianne sent out will have a little bit more information in there about NAR and FAR. NAR is the National Alliance. And so I won't be talking too much on that, but it's there for you if you want to read up on it. All right, so currently throughout the state of Florida, we have 107 programs certified. If you can see the trend, the one interesting number that I added on here by request of Maureen, that we put in the number of programs that are actually gone through our MAT assessment and are certified as MAT housing. It's an interesting number. You know, we have 6,975 beds certified, but 2,435 are actually claiming to be MAT houses. So, you know, we obviously have an issue to look at there. I have a couple of plans in place that I can discuss with you if you'd like about how we're planning on trying to improve that number. And then as far as the levels are concerned, in layman's terms, the level 4 is the housing component of a treatment center. So if you're in their housing, you're in their treatment. And that's why I separated them from the levels 1, 2, and 3, because the 1, 2, and 3 is a better indicator of housing capacity for those that are not in treatment. The level 1 is peer supportive. 2 is your more traditional, but has a housing or house manager that's typically the senior resident. And level 3 has a clinical component to the housing. So we have, so you see those numbers. When I say units, I'm talking about locations. Even though I have 107 providers, a lot of them have multiple locations. Some of those locations are duplexes and or apartment complexes. So there's lots of, a lot more units than there is locations, obviously. So we're looking at units, then the beds are self-explanatory. We break it down for you here by men, women, both. It's not co-ed. Both means that it's a program that serves both men and women, but we currently do not have any certified co-ed programs. I'm scrolling down here to the county breakdown. You can look at your county and see what we have going on there. I think the point of note is the percentages that I have listed there. Broward has 32% of the units and 32% of the beds. Palm Beach County has 42% of the units with 38% of the beds. I mean, of statewide beds. So obviously we got about 75% of our resources are here in Palm Beach and Broward, where the rest of the state makes up for the other 25. I put the running totals here for Palm Beach County. We have 51 programs certified in the county and 2,674 beds with the breakdown. And then this is the new number that I added of 1,147 are actually MAT houses. I put that just so we have an idea what we have for capacity in the state and the trend since 2017. You can see how we've more than doubled our beds, and I also put Oxford numbers in there too because that is part of the housing capacity. Oxford is exempt from state legislation that requires places to be certified under certain conditions. The overdose numbers since March 1st of 2021, so roughly a year, certified residences are required to self-report. So, and I always like to throw in this, that I really do believe that they do a good job of it because we live in a community where, those kinds of things don't go unnoticed. And so I don't think we have a problem with people failing to self-report. If they do, it's only for a time being until we, call them and remind them. But 48 total in the last year, 38% of them were deaths. If you look at the next section down here, the 1-year averages in December of 2020, 69% of the overdoses in FAR certified houses were resulting in deaths. And as you can see, down to December of last year, that's reduced to 32%. I personally feel that is mainly of the presence of Narcan being easily attainable, but there could be some other factors. Okay, here's your breakdown of your city reports. I would like to make talk about Delray just for a minute, because at the beginning of this meeting, we had they talked about the Delray numbers. For the last year, I've had 11, but my year for this report is March to March. But I'm gonna scroll down. What did I do with that other report? Hold on a second here. So this is I was just taking a little note here. This stuff is stuff that I'm working on for future ones. But in 2020, if those numbers are accurate that Delray provided, in 2020, I'm down here, by the way. If they had 63 overdoses, only 6 of them, I only had 6 reported in Delray Beach, which would have been 9.5%. In 2021, they said there were 41, possibly down to 35 after we get the results of those other 6. That means that in 2021, 34% of the overdoses in Delray Beach were in certified recovery residences. And if that 6 drops down, that means 40% of the overdoses in Delray were in sober homes that are certified in Delray. So that's kind of an interesting number for me. I'm kind of thinking maybe just as an idea that it might be because it's, with fentanyl being the cause, a lot of people, when they get a period of abstinence and then they go back to use, sometimes they take a little bit more than their tolerance will allow. And so that might be the case, but I just figured I'd throw that number out there for discussion. I found it to be interesting. And then previously I'd been requested to put age reports and drug preference. The average age is 32.33. I don't think that's a big shocker. Opiates were 40%. So when somebody overdoses in these reports that are coming from our certified recovery residences, we ask them what the person's drug preference was. This is regardless of whether they died or whether they were revived. And so I don't think those numbers are any surprises. One of the doctors from our Palm Beach County Coalition asked if I could start reporting how many doses of naloxone were given. And so 3 of them were given 1 dose, 7 were 2, 1 was 3, and 2 people were given 4 doses. That 4 reporting number, I just thought that's not accurate. There's a lot more than that. You can add those numbers up and find out how many people have reported. Certification levels, level 2 having the highest number. That's no surprise. That's the least amount of supervision other than the peer support level 1s, which we really don't have very many of. And if they came to Florida for the purposes of recovery, that I asked them for the state that they came from, the time that they were here in Florida. And there's your breakdown there. This one guy here was only here for a day. It's quite unfortunate. And the rest of it is just FYI information for yourself, for everybody. I was going to discuss this little down here, but I'm going to wait until it's actually approved, because that's not going to be approved till the end of March. I'm not going to get it too far ahead of myself, so I'll report on that at the next meeting. But that's all I have. Are there any questions for me?
Okay, no hands are raised, so thank you very much. We'll be discussing the disparity in certified houses around the state, especially in light of the number of overdose deaths in, say, Hillsborough and County, for example, and Pasco, Pinellas, Jacksonville. The fact that there are so few beds there, and we're hoping that the legislation that passes here will give us an opportunity to scrutinize those treatment programs that are in those counties or elsewhere in the state when there aren't any certified beds. What I mean is that there's going to be a requirement that any DCF facility, any treatment facility licensed, is going to have to put into the DCF database what recovery residences, sober homes, that they have a relationship with. And that will make it a lot easier for DCF to oversee and make sure that they're not violating the law by referring or accepting referrals from non-certified recovery residences. It also gives the state attorneys an opportunity to be able to prosecute, if appropriate, in those jurisdictions that are trying to fly under the radar. So we'll talk about that later. Okay, Lori Holsclaw Hunt for Oxford House.
Hi, everybody. So our numbers this month, well, as of February 22, we have 86 houses with
Wow.
700. Can you hear me?
Yeah, I just said, wow.
Yeah. 734 beds. We are looking for new houses in Palm Beach County right now and several other areas, but specifically Palm Beach. We are also still looking to replace the house that, so as everybody knows, the market's been kind of crazy. So one of our homeowners decided to sell. And so we're still looking for a replacement house for that. And we're also looking for new houses in Palm Beach County. We had one non-fatal overdose. It was in the Tampa area since the last meeting. And then I also have that resident profile that you asked about. So I'm going to share my screen and kind of go over that with you guys. Now, this report is from last year. We do the resident profile once a year. So the information was gathered last year for 2021, and we're probably going to be doing it in the upcoming months. So I'll have a new one over the next few months to share with you all. Okay, so this is the Oxford Houses of Florida 2021 member data survey summary. Oxford House collects data monthly from each house with respect to applications, admissions, expulsions for cause, and voluntary departures. Member profiles are obtained using a confidential survey questionnaire. This generates data that can be compared on a year-to-year basis. The house figures below are current as of June 2021. Member profiles are derived from a state survey conducted in 2021. Data noted in bold represents the results of a confidential survey given to all the members living in Oxford houses in the summer of 2021 over 4 weeks. Responses were received from 389 of the 457 individuals in residence, yielding a response rate of 85.1%. So at the time of the survey, we had 69 houses, 12 women's houses, 15 women with children's houses, 41 men's houses. 389 people participated in the survey, and the beds filled were 457. So, and then it gives you a percentage of gender. So over here, the Oxford House beds of 630 was 569. So not all the beds were filled. And it goes through the women and men's. And the average cost weekly is $154 a week. It ranges from $100 to $200 a week, depending on the area. Rent per group, that's like the rent to the landlord, is about an average of $2,800 a month. Now that, that varies from North Florida to South Florida. The average number of applicants for each vacant bed was 1.82. So our average age is 37. It ranges from 19 to 68. We have a race breakdown. 79.2% was white, 7.5 African-American, 4.4 Hispanic, 1.8 Native American, and 6.2 multiple races. And then we give a breakdown of marital status. Most of our residency is never married. Some are separated, divorced, and only 6.4 are still married or are married at the time of the survey. Average years of education, 12. Average monthly earnings, 2890.45. Military vets, 8.23%. And then we didn't collect, I don't think we collected the disability or student. So percentage reporting prior incarceration, 69.9, which is pretty average. It's a little bit lower than our national average. I think it's like 76 on the national average. 2 times arrested before and about 6 months served. So percent addicted to illicit drugs and or alcohol non-opioid is 32.9%. Percent reporting opioid abuse, abuse of opioids is 67.1%. So the percentage that have attended just detox with no treatment over a lifetime is 63%. And then the percentage of prior residential treatment over a lifetime is 86. So at least they have been to a treatment at least one or more times over their lifetime. The average number of attempts at sobriety, averages 4, medians 5. Percent going to weekly counseling plus mutual aid meetings is 38.3%. And then the percentage going to like AA or NA, 99.3%. The average meetings attended is 5. The length of abstinence is 9 months. The average length of stay in Oxford House is 7 months. And our monthly abstinence rate is at 92%. So does anybody have any questions?
Al, can I jump in there?
Sure, John,
Lori,
go
thank
ahead.
you. Yeah, Lori, that was absolutely great data. I really appreciate you sharing that with us. Is there any way to get the national to break that down just specific to Palm Beach County? You know, because that was Florida statewide, so would love to be able to see that for Palm Beach County as well.
You know, I've never had anybody ask to break it down per county. So that's something that I would have to ask our data specialist about. And we could possibly do, because they're anonymous. I can't remember. I think they put the house on there. We could possibly look at that, like by house. Or I could possibly have just a survey done for Palm Beach County.
Yeah,
so
no,
that might be something we
I'm
could
hoping your
do.
data folks could break it down by Palm Beach, but I definitely appreciate you looking into that. But that was really.
We could do it this year, just because we've just never done it before, right? Per county. We can look at, because the survey is going to be upcoming in the next few months. So I could just have them specifically do it for Palm Beach County.
Thank you.
Lori, can you give us the new survey data in June?
If we do it by June, yes, absolutely.
Otherwise, the following meeting which would be August.
Mhm.
Okay.
Yeah.
Excellent. Any other questions?
I'm going to have to get off early, Al, but Tyler and Chandra and Elizabeth are here. So I have another meeting that I have to get on in just a few minutes.
Okay.
So of course, if anybody has anything they want to talk about, you can always call me or email me and we can set up a meeting, or if anybody would like any presentations done or anything like that.
And there was a question as to how many of the houses are accept MAT in the Oxford, in Florida.
Okay. So all of our houses are MAT friendly. All of them throughout really all through the whole country. So basically we can't discriminate against medically assisted treatment. So we teach and train all of the houses to be accepting of medically assisted treatment. Now, does that, do houses so there is also still stigma out there as well. So every now and then we'll get a house that decides they don't want to do that. If that happens, or if someone hears of that happening, please call us so we can go over there and retrain the members and, just explain to them how important it is for people to be able to have an Oxford House with that are on MAT. Now on the report, we do have a pretty high percentage that are, almost half of the people in Oxford House are on MAT throughout the state. So it's like 44 point something %.
Okay, thank you. Great. Thanks, Lori. Appreciate it. And good luck with your other meetings. Now, we have Ann Berner here from Southeast Behavioral Health Network, and she has a few updates to share.
All right. Thanks, Al. Go ahead and get this up. I just put something together just to kind of follow along. So hopefully, are you seeing my cover slide, Al?
Yes, yeah, it's fine.
Okay. So one of the things that you had asked me to talk about today was not this. There we go. So just kind of following up on Steve's report, Steve reported out on the number of units and beds in Palm Beach County. And what we require is that in order for a recovery residence to be eligible to receive a transitional or a housing voucher, they have to be fully MAT accepting. And so we do it a little bit further than what the FAR certification would require, in that they do have to accept all of the available MAT treatment options, so including methadone. And then we also, a lot of the homes, when we talk to them, they kind of have a cap on how much medication they can take and still be eligible, or an expectation that they have to taper off by a certain time. So we've, all the homes that we've contacted in Palm Beach County, we only have these homes that actually meet kind of all of our qualifications. And then we also within our treatment network, then we also contract for community housing, which uses recovery residents. And so that's our list of treatment facilities that we work with as well. And I think let's see that. So the issue of kind of getting people to be MAT acceptance is still out there, and it's a little surprising that maybe we haven't made it quite as far. But I do know that Steve and his staff are working hard to make sure people get educated and have that option. So that was just kind of a highlight and just kind of a follow up to Steve's. Of the 51 certified programs in Palm Beach County, this represents 11 agencies that we will refer clients to and support with a transitional voucher. So any questions there before I go to a quick update on our legislative appropriations?
Nope, go right ahead.
Okay, so it was, as some people alluded to, was a very good year for behavioral health, and in the it was about 126 million in recurring appropriations. And so I just wanted to kind of outline the requirements for that. So this is actually most of the proviso language that's associated with it. And I think probably the interesting pieces are that we do have to go back and we have to prioritize the team treatment approach across the state. So that includes a community, children's community action team. We have a child welfare program called Family Intensive Treatment. And then we also have the Florida Assertive Community Treatment Model that takes some of our most severe individuals coming out of state hospital and having kind of chronic long-term mental illness. And then the other exciting part is kind of reinforcing our mobile response team. So that's going to take the first cut of the money. And then the rest of the balance of the funds are going to be distributed to the managing entities. And the directive is to look at these priority areas. So coordination of care, increasing residential, reducing wait lists, investing in our provider workforce to improve and increase stabilization there. And then any of the money that we do get is limited to the managing entities only taking up to 2.5% in admin. And then we're working right now with DCF to come up with a very specific spending plan, because they do have to go back to the legislature and get approval to have those funds dispersed. So we are working on getting that done right now. Let's see. And so just in highlight, there we go. So it's basically 126 million in recurring general revenue. There was a change in how the FACT teams were funded last year, and that created some problems because there was some miscalculation about who on the FACT teams actually received Medicaid, and then of the Medicaid, there was only certain types that were eligible to be reimbursed under the FACT team model. So we've got the FACT funding, we hope, corrected, and then we also have additional money designated specifically for some additional teams. We are looking at about $20 million in community forensic beds. in our discussions with DCF, we are hoping that we have about $1.5 million set aside for forensic beds here in Palm Beach County. Good news, there was a lot of member projects that were funded. So a little over 43 million in non-recurring. I believe Hanley, the project for Palm Beach County that Hanley had discussed, I think last time, is included in that budget that's been sent over to the governor. And then, more importantly is, we were able to sustain all of our current year funding and the specialty areas. So the state opioid response grant, the opioid lawsuit funding, and then some of the COVID relief will continue for 22-23. And then we had also the current year level funding. So we continued with our base and the projects that were previously identified there. So all in all, it's a pretty good year. Generally speaking, Southeast Florida is about 10% of the state's managing entity allocated funds. So in a good year, in a average year, we are hoping to get about 10 million, and Palm Beach County represents about 66% of our funding allocation, because we also manage the other 4 counties to the north. So anything over 10 million for us collectively will be a good year. So we are making sure that we've got our enhancement plans, which are a statutorily required item, and then also working with our stakeholders and finishing up a needs assessment that hopefully many of you have been involved in. We've got some focus groups going on this month, so that we will be making sure we've got the details we need for DCF to submit for legislative approval. So it's just a high level overview, just to kind of put some context to the numbers that we were looking at.
Excellent. Thank you, Ann. Any hands? Any questions? Okay, appreciate it very much. Hopefully it's been a good year in a lot of respects with regard to allocations. So so hopefully we can get a handle on the epidemic. But again, fentanyl is the driver that's causing so much in the way of overdoses and death. But the number of people who are addicted, I mean, that's a different issue, and that need treatment, that's a different issue. But thank you again, Ann. And now we're going to go to the statutory enactment. We were successful in getting our task force legislation through the House and the Senate. Since our last meeting, there was one addition. There was one amendment, and we'll be talking about that. But so we'll just review. We had 3 different asks. One was that recovery residences, licensed treatment providers, as I said earlier, they need to record their relationships with recovery residences in the DCF database. It makes it easier for DCF to track anyone who is scoffing the law. And it also adds a $1,000 fine per occurrence if recovery residences are, the treatment providers, because they're the ones under license. $1,000 fine per occurrence for the treatment providers that are engaging in referrals with non-certified recovery residences. This is really important because, again, as I looked at the numbers from FAR, Broward and Palm Beach County have it, we've got it down. That's 70% of the beds, a little under 70% of the units. But then you look at some of the other counties that should have more, like Hillsborough with only 334 beds, and Miami-Dade with 72 beds, 9 units. Pasco County, Pasco Pinellas, which had the largest number of overdose deaths, opioid overdose deaths, have a total of 65 units in the 2 counties and under 300 beds. So we have a ways to go, but this will at least give law enforcement and DCF the opportunity and to be able, without great expense of time and energy in investigating, to be able to monitor compliance with the certification laws, the mandatory, the voluntary, but mandatory for those who are engaged in referrals. The second thing is recovery residence administrators. We had become aware in the task force that because a unit could contain a couple of hundred beds, it could be an apartment building. If you recall the old watershed, that was like Century Village. I mean, there were blockhouse apartments, and so one recovery residence administrator could oversee one unit that had over 100 residents. Maybe 3 units could have 200 or 300 residents. And so what we did was we cured that, and we also put in a preamble in 397-4871. That's let's see. Do I have control over this? Okay. Let me get to where we need to be. Here it is, 4871. The preamble is important because it says the whole purpose of the law is that recovery residence administrators have to demonstrate the ability to effectively and appropriately respond to the needs of residents. If you're one CRRA and you've got 200 or 300 residents, there ain't no way you can respond to the needs of the population. So instead of going by units, because the average sober home, and Steve, please correct me if I'm off base on this, but an average house would have anywhere from 6 to 10 residences, depending on the number of bedrooms and the square footage of the house. So, you know, being limited to 3 units when there are only 7 living in a house or 8 living in a house, you know, that recovery residence administrator might be able to expand to a 4th or 5th unit. But if you have 100 residences, then you have to get permission. There should be 2 CRRAs in that apartment building, unless FAR reviews and finds that the CRRA is able to oversee 100. But the maximum is now 100. We got a little bit of pushback on this one, but I think it clarifies and gives meaning to the fact that a certified recovery residence administrator actually has the ability to oversee the residents. Then another, we got a little pushback on this, which is the rights of individuals. 397-501. And we had gotten many reports that service providers were holding property, having patients sign a 48-hour retention of property. And these are not lockdown facilities. If a person wants to leave and they leave without their identification and their wallet and their driver's license and their phone, you really are putting them in danger. Now, there is the counter argument that if somebody's leaving against medical advice, that puts that individual in danger, because the odds are they're not ready and they'll be looking for drugs. But people on a daily basis, hundreds of people in Palm Beach, well, you know, in the state, I would say maybe even in Palm Beach County on a given weekend, are leaving our area hospitals AMA. And they're in much worse shape, arguably, because they're in withdrawal when they do so after being administered Narcan. So, I mean, you know, there's an argument, there's a counter argument, but you know what? I had a conversation with a lobbyist, and this, in my opinion, and of course, you know, this is DCF's opinion is important here too, because they're the ones who oversee this. There's no criminal penalty for not returning the property. It's a civil matter, but I don't read this, and I'd like to hear from anybody on the call, on the Zoom, who does. I don't read this as somebody's leaving and you have to immediately, you know, get all their property, give them to them as they're walking out the door. You know, I think there is a reasonable amount of time because it says upon the individual's discharge. Now, if an individual wants to leave at 12 midnight, the discharge isn't going to happen till the morning when staff is there. And I don't think that this, in my read of this, and of course the legislative history, there's not much, but we vetted this in our task force and talked about it. I don't think that means you let somebody go off into the night at midnight, but you don't tell them they got to stay for 48 hours because they're likely to leave anyway without that and be in danger. But okay, when staff comes in, we'll have a meeting and you'll be discharged and you can have your stuff and you can leave. Again, you have to look at a statute like this to a reasonableness factor. So 8 o'clock in the morning, a provider can't keep somebody till midnight till they give them their property. That maybe is a couple of hours to process the discharge. At midnight, it might be a little bit longer. Anyhow, hopefully that enlightens like a construction of the statute. And the last part of the statute that I want to talk about is the add-on, which is the fourth prong, and that's contingency management. Which the more I read into contingency management, I see that it's a useful tool and it's a best practice when it comes to stimulants. It has not been vetted, it has not been peer reviewed when it comes to opioids or when it comes to other non-stimulant type drugs or substances. However, having contingency management available, the amount of money, what contingency management is, it's basically giving somebody a reward. It's a reward-based, it's an algorithmic reward-based program. It's not like, somebody just decides to give somebody $5 for getting having a negative urine test. But it's through an algorithm and it's a program and a process for all patients. It's supposed to be working across the board the same way. And the amounts are not significant. So there's less of a chance that those rewards, using air quotes, will be just another name for an inducement for somebody to go into treatment at a particular provider's place. An example would be if it was unlimited, you could give hundreds and hundreds of dollars to a patient during the course of the month in gift cards, etc., and call it contingency management. But really what it is another name for patient brokering, meaning intending to induce somebody to go to a particular treatment place. So the limit on SAMHSA is $1,500 per contingency and $75 per year. There's you have in your packet an Inspector General opinion, Office of Inspector General. Very interesting. They talk about a specific digital program that is offered to providers. And the facts have to be the same as the facts given to the OIG. It does not apply to state law. It does not apply if the program is controlled by the customer, which would be the provider, the treatment provider. And the incentives have to be less than $5 to $10 per contingency, but they do have a maximum of $200 a month and an annual maximum of $599. In my opinion, that's a little bit much for, say, an OIP program that's 5 weeks long. That's $400, but the facts of this limit it so the provider can't control the contingencies, and so it shouldn't be a problem. So that's also in law. That was amended midway through the session, and so contingency management programs, as long as they're approved by the federal government or SAMHSA or DCF, are allowable. And I know that that Anne was looking into this as a useful tool for the Southeast Behavioral Health Network in terms of their best practices. So that's our statute that was passed. I noticed that Dave is on the Zoom, and I want to talk a little bit about SB 190, the fentanyl test strip exemption. Now, when we were in Tallahassee, Dave and I, for the first week of session, we were talking to some folks, and all of a sudden, we got this idea that it would be really helpful in a fentanyl epidemic where so many people are dying without knowing that there's fentanyl in the substance that they're using, to have a simple fentanyl test strip to be able to test the drug and eliminate fentanyl. In other words, those West Point cadets, those 6 college students that were in that house and all overdosed and went to the hospital, they went to get cocaine. They did not go to get, and don't judge, but they went to get cocaine, not fentanyl. And yet 2 of them were in critical condition, probably may have brain damage if they've survived. I haven't heard anything else than they were in critical condition. So we got this idea, hey, let's borrow some language. I was looking up there are, what I think Dave's looked it up. I think there's 18 states that exclude fentanyl testing products from the definition of drug paraphernalia. Right now, fentanyl test strips are illegal in the state of Florida because they fit the definition of a testing process for drugs, which is considered drug paraphernalia. It's a first-degree misdemeanor. It's ridiculous to be prosecuting a testing apparatus to test for fentanyl when we know that most people who die of drug overdoses in the state of Florida that involve opioids, fentanyl is the cause, and the other drugs are not opiate. The other drugs like cocaine, methamphetamine, Adderall, for crying out loud, Xanax, marijuana, cannabinoids. So with that, I want to turn over to Dave, because we had a severe blow in the House on the last day of the session. And I'll turn it over to Dave. Hi, boss.
Hey, Al, thank you. And yeah, it was really disappointing because we worked hard on this and we thought we were getting it through. It passed through the help of Senator Jason Broder, who added it to his bill. And then Senator Pizzo was a great advocate. And they even praised us on the floor of the Senate as this bill passed in a bipartisan way in the Senate, and then went over to the House, and the House refused to adopt the bill. They took the bill and stripped out our language. And I was told it was because there was a staffer in the Speaker's office who was against it. And you know what happens in the House, especially because of term limits, you have people who are only there 8 years and they look to the Speaker for leadership. It is not a true democracy. It's sort of like a top-down form of government where the Speaker controls, and the staff, which is there forever, which is not subject to term limits, has inordinate power. And so there's someone, maybe the chief of staff is what I had heard in the Speaker's office, who didn't like it because that person believed in the old school way of thinking that drug abuse is a moral failing and not a brain disease. And so this will encourage people to use drugs. And then the next day you had West Point cadets overdosing on this. And, you know, the same people who love to tell individuals in the military, thank you for your service. We are so appreciative of you. Well, prove it. Prove it by harm reduction. Here are students who did what unfortunately a lot of students did. They made a mistake and did something stupid, but as a result, they should die for it. I mean, it doesn't make any sense. And 2 of the cadets apparently were not using cocaine. They were giving mouth to mouth to try to save their friends' lives, and they had to be rushed to the hospital for a fentanyl overdose because of the transmission of this very potent drug. So that's where we were. It didn't even get, well, it got voted down in the House on a voice vote, even though there was no one who spoke against it, because there really is no argument against it. But, you know, that's what happens in the House. The head person, the head office says vote it down, and so the minions just do it, even though not one person spoke against it. So it was very frustrating, and I won't remain silent on it. I did an interview with Channel 25 yesterday that went on the 6 o'clock news, and now I just did one with Channel 12, and I just did one with Tony Mann of the Sun Sentinel. And so we're going to, you know, try to get this out as much as possible. I don't speak to the Palm Beach Post largely, so that's if you're wondering. But that is, so we're getting this out there because this is to me, a matter of life and death. This is such an obvious no-brainer where you're talking about something that could save lives without any cost to the state. And it will pass eventually. I think it's going to pass next year once we redouble our efforts and start working on this earlier instead of just adding it midway through. In fact, several Republicans apparently approached a Democratic member of the House and said, we want to work with you on this for next year. The tragedy is that how many thousands of people will die in Florida in the next 12 months because of the Florida House's inaction. So that's where we are. I'm calling out the Florida House on Twitter and all the, I'm going to continue to do so because, we need to call out those who refuse to do the minimum to save lives. They'll legalize syringe exchange programs in certain counties. They will allow the freaking use of Narcan. But when it comes to now a very cheap strip that could help identify this dangerous drug, no, that's they can't do that. One last postscript on this. Congressman Ted Deutsch has been very helpful on this. Ted Deutsch, his nephew, 20 years old, overdosed and died of a fentanyl overdose. He was a student at William and Mary, a really good kid who was using the legal drug of kratom, which is found on our streets, on our kava bars. And as a result, died of an overdose because it was laced with fentanyl. And so this is the kind of thing that would have saved his life. And Congressman Deutsch has been an outspoken advocate for this measure. So we're going to keep pushing until we get it done.
Thank you, Dave. Just as a postscript to your postscript, and I said this earlier, we give credit to the state that we borrowed the language from, Arizona. The legislature of Arizona is hardly a bastion of liberality. And they passed this because they understood that this is a harm reduction method of preventing overdoses and deaths. And we've been having our analysts crunch the numbers on the, remember at the beginning of the meeting, we talked about the 6,089 opioid overdose deaths in 2020, according to the medical examiner's report. We have, bless you, Dave, we have their raw data. And okay. Fentanyl and cannabinoid, just fentanyl and cannabinoid, which means that the marijuana was laced with fentanyl. 1,153 deaths in 2020. How many of those deaths could have been avoided if people were on the lookout for fentanyl to make sure that the drugs they were using didn't contain fentanyl? Cocaine, methamphetamine, and methamphetamine, okay? Fentanyl as the cause or present in 3,224 overdose deaths. Right now, we're now at 4,000, almost 4,500, 4,400 deaths that may have been avoided with a $1 test strip sold out of CVS. But we can't do that because it's illegal right now in the state of Florida to possess a fentanyl test strip. So that's how bad it is. We're not beating around the bush. Dave and I will be beating the drums, as they say, for the next 12 months. And we will make sure that there won't be a 2023 where people are dying inadvertently because fentanyl is killing them and they don't even know it.
Thank you, Al.
Al, I know that I'm not supposed to speak in here, but as an expert.
Scott, you go ahead. Go ahead, Scott.
Yeah, I'm an expert on this stuff, okay? Those strips are actually detecting exactly what we need to be detecting. I do not understand scientifically how anybody could ever override that fact. Look, Dave, Al, all of us, we have to stop and think about this. What in the hell is going on here? Pardon my French. Scientifically, it just makes a whole lot of sense that we test for these things in order to, once again, avert death. What is it that we're looking for beyond that? We're looking for harm reduction, yes. And I'm having a really hard time wrapping around the legislative part of this. But I'm here if anyone wants to talk to me about it at any point. I do understand how these test strips work. I helped develop some of those strips a long time ago when it had to do with other drugs. And it's just part of what we do to test for illicit drugs. I'm not sure where this state, look, other states are clearly way ahead of us. And the one that which I'm from originally, North Carolina, is way ahead of the game on this. So what is it about Florida that makes us seem so different? I don't get it. Scientifically, I'm having a real hard time. So anyway, I'll end with that and thank you.
Thank you,
This is
Scott.
not uncommon. This is, I mean, same, people that say, any sort of harm reduction, giving out condoms is going to increase sex and you're getting people to have sex. I mean, any harm reduction, their philosophy is it will increase use and you're then giving permission for people to use, which is obviously ridiculous. And research shows that it doesn't work and that this does work. So it's fear.
Rachel, and Scott, that gives me an idea. One of the things that Dave and I are a bit connected with the federal government in terms of the studies that are coming out, the commissions that are being appointed. And I think this needs to be one of our priorities on the federal side to get SAMHSA or one of these commissions that's looking into harm reduction to endorse the fentanyl test strips for consumers. And I think that might go a long way, although maybe not in Florida, but we'll try everything we can.
Al?
Yes.
Yeah, this is Uta.
Hi, Uta.
SAMHSA has actually, they used to be very against the testing strips, and it was kind of a bizarre thing. I mean, they doubled down on the SOAR grant not being able to purchase the testing strips, but they recently made a complete 180 on this and actually put out harm reduction grants that included any kind of testing strips, whether it was fentanyl or even other drugs, Narcan distribution. I mean, they had 12 different harm reduction tactics. So SAMHSA is already on board with this. And as a matter of fact, states like us where providers wanted to apply for this had to literally name their state statute that would not allow them to distribute the fentanyl strip. So SAMHSA has definitely changed their mind on that, but we know that, it takes Florida always a little bit longer.
Thank you, Uta. I appreciate that.
True.
Can you send me, if you have access to those programs that SAMHSA has approved for their.
Yes,
programs?
absolutely. I'll send you that.
I appreciate that. That'd be great. And I'll introduce it to everybody. We are full court press on this for the next 12 months. So this will be a topic of conversation for our next, for the next legislative session, and this will be a priority. Any other comments or questions? And I'll open it up to anybody. We are ahead.
I have a question.
Who is this?
Michelle, I have a question. I want to know what was the legislation or what happened to it concerning peer specialists and the 5-year background check that DCF and such was supposed to not go past to allow more peer specialists into the workforce, because obviously it's not what happened.
The peer specialist legislation passed fairly early in the session. So I'll bring that to everybody's attention at the next meeting. I don't have it here. It's been a priority of the senator out in Hillsborough, Dave? Who is the sponsor of that? The peer
Roussan.
specialist.
Oh, Roussan.
Yeah, Senator Roussan.
Pinellas.
Yeah, and Pinellas, and he got it passed this year. I believe it does ease some of the restrictions, but we do have the 5-year on and the exemption part as well that we passed. We got the legislature to pass, I think, either last year or the year before. So I know there's some hiccups there. Whitney Lehman and I had talked about one CRRA in particular that DCF did the right thing and passed them through. But so I can't. The peer statute did pass, Michelle.
Well, I just tried to get a job for the second time with New Horizons, and DCF on their exemption wanted me to go back 30 years worth of court records with locations, including the county, that won't have records that are 30 years old. And again, now lost that job for the second time because they didn't stop at 5 years till today. They went back the whole entire arrest record of.
Have you appealed? You do have a right to appeal that decision. Did you do that?
I did, and they said, "Well, no, we want you to go to each Riviera Beach, Lake Worth, wherever else, and get the actual arrest record." I'm like, those are 30 years old. Oh, well, if you can get them, or you can get the state attorneys to write it off and say that there's no way to get those records. But I did send you all that information. So just wanted to put that out there that, some of this draconian stuff is killing your workforce, because even when I was in New Horizons that day, I was told not even just peer specialists, but people that have gone through, spent thousands of dollars getting MSWs and such, then they go to get these jobs knowing they had a arrest record way back when, but they've got all this, still can't get that job.
Michelle, thank you for bringing that to our attention. Susan, I hate to volunteer you, but do you think you might be able to just look at what Michelle's going through and see if
Of course, Michelle, reach out to me. I'd be happy to walk you through this if I can.
yeah. I mean, there may
Okay.
be more to it. I know that one of the things we resolved,
Thank you.
because we worked to resolve that for you, and then something else came up. So I don't know what that is, but again, I think we need to have all the details of that. And thank you, Susan. I would ordinarily call you and not ask in front of 45 people, but you're the
I'd
best.
have no problem saying no. No is a complete
Okay.
sentence. I'd say, nope, not me. Nope,
All right.
please call me Michelle.
All right, thank you. Anyone
You're
else have any
welcome.
comments?
Al, just real quick, I
Yeah,
had
John.
put into the chat what I had sent you and Dave back in December, a deeper dive on the fentanyl test strips and an analysis of what other states are doing, but appreciate your and Dave's work on that issue. Thanks.
You're welcome. Thank you. Okay. Now we've got folks from Overdose Data to Action, OD2A. We have Whitney Van Arsdale here, and she's just going to give us an update on, I guess, the last couple of months. So Whitney,
She's going to share the screen.
Hi, yeah, I'm sorry. I just had to set up my PowerPoint. Let me open it up. Can you guys hear me okay? I got a new mic, so I don't know.
we can hear you. You're going to share a screen, or what do you want to do?
Absolutely. Switching. All right, you guys see everything okay?
Yep.
All right. So just to jump into some of our updates here at OD2A, for 2021, we are about 85% done with our non-fatal suspected overdose data. The remaining bunch is a drop that we recently got from Delray that we really want to include. Delray is normally a big chunk of the ED visits for overdose. So we're trying to work fast to incorporate all that and get out the complete 2020 report to you guys very soon. For fatal overdose data, we're about 70% completed. Al, you mentioned earlier that there's still a few more rolling in. So we're waiting on the medical examiner to finalize those and get that out. That we're expecting more midsummer, probably. And then for 2022, we are putting together monthly reporting on emergency department and EMS data. There was an update. I know we released January 2022 data last month. We had a updated system parameters for the EMS data. So now it's all 15, whereas before I think it was 10 of the EMS providers. So I amended the report and I'll be sending that out probably tomorrow, but I'm going to present that now anyway, so you can see the changes in the data. Too much. Sorry. Okay, so for January, EMS events were decreased 19% from December, whereas ED visits had an 11% increase. For the areas most affected, you're going to see that West Palm Beach area out towards Loxahatchee had a high incident rate in January, and then down towards Delray. The next map is a percent change, and I went ahead and I kind of redid this map to be a little less busy. Before it had different levels of percentage. I just made it very straightforward so that more people could digest this information easier. So the green is where cases went down for EMS, and the red is where cases increased. I know you guys were interested in the other data from other agencies other than Palm Beach County Fire Rescue, so I started looking into that. Still, Palm Beach County Fire Rescue made up about 60%. West Palm Beach and Delray were the next largest, and then there was another 12 agencies making up the other 20%. Overall, Delray EMS, and I'm sorry, this is just EMS events for this timeline you see on the bottom left. That's a typo. But the EMS events did show a general decrease over the past 3 months. And then the hospitals, typically what we would expect were JFK. Maine is seeing a lot. Delray, like I said, we're getting a big dump from them from the end of last year. So they're one of our top hospitals that provide us data. And then you have Bethesda East as well. And then finally on this page, the bottom right, most of the substances were opioid. There were also a good amount of stimulants under the non-opioid section, and then polysubstance. Similar to what we've seen over the past year or so, most of these are reported as opioid unspecified, which we think, just our opinion, we think that that's largely fentanyl, but they don't call it fentanyl. So, we're hesitant to label it anything other than what the discharge diagnosis says. So we did notice that you guys were interested in the youth overdose data as well. So we did incorporate some of that into this report. So you can see that youth being children aged 0 to 19 were more likely to be female, more likely to be a minority, and then also have a higher rate of intentional overdose. Mostly it was non-illicit substances, but there were some opioids and then other illicit substances, about 6%, and that was primarily amphetamines and occasionally like a benzo. I also thought it was really interesting, the discharge diagnoses for the youth overdose patients. More than a quarter had a depression diagnosis, which reflects back to a lot of this higher rates of intentional overdose in children. And it's just concerning to me. So we're definitely keeping an eye out, and it kind of sparked my interest in these opioid overdoses. So historically, I pulled data back from 2000, and there was only 4 heroin overdoses and 5 fentanyl overdoses ever recorded in our systems in Palm Beach County in the emergency departments. And 3 of them happened in the first month of January. So these are children under 4. They had a discharge diagnosis of fentanyl, and all 3 of these overdoses occurred within a 2-week time period in infants less than 12 months old. So it was concerning, to say the least. I just checked the numbers again recently, and we haven't had any further spikes or anything like that. But it is definitely something that we're going to keep our eye on going forward. Moving into February, there was a 19% increase from January, with our numbers being similar to that of December, which were pretty high. The emergency departments increased as well, but only about 4%. 18% of the discharge diagnosis for the EDs included heroin, and then 13% included fentanyl. And then again, you see on the 2 maps I have, the first map is going to be the incident rate, which was highest, actually that north, I forget that region, north of Pahokee. It had the highest incident rate, but again, I want you guys to keep in mind, they have a much smaller population, so the number is actually probably pretty low if I go pull that specific number. But the rates were overall continued to be high in West Palm, all the way down through Del Rey. For the percent change, you did see a lot of the areas that were red before have turned green, like that large Loxahatchee area. There was no change in that northern Pahokee, where it has the high incident rate, so it's same as last month. And then down towards the bottom of the county, there was an increase in overdoses. So this bottom left time chart does show EMS and ED data over time. This is 2 months data due to our hospital collection. I can only do 2 months for that right now. And it does show a general increase for EMS and a very slightly, but still an increase in ED, reflecting that 4% increase from the previous month. We also started looking at things like why EMS was transferring to a particular facility to investigate, where they're taking them and why. 64% were taking patients to just the closest facility. 20% was not reported. And then we also have reasons like protocol, which I'm led to believe that would be very similar to closest facility. They also have patient's choice, and then if they're going to a specialty center. Opioids were the most reported drug. This really hasn't changed from January. Stimulants next highest, benzos, and then you'll have a poly drug use of all 3. And then we started looking at the discharge diagnosis. Most of them were discharged, but 1 in 6 patients did require hospitalization following an overdose. And then I kept the suspected overdose in youth age 0 to 19. We're going to continue to keep an eye on it. So February saw the rates increase for both males and females. Depression again was reported in 1 in 5 youth in February. And then we're seeing a slightly older distribution with a lot of that 15 to 19-year-old range. And then for our monthly highlight, we really just kind of wanted to do something looking at, social determinants of health, and the CDC released this data set that's really amazing. If you have time, go to cdc.gov/places. They have a very interactive map where you can learn more about the different chronic disease risk factors. And you get to actually play around with some of that data as well that I used here. So you'll see this first map to the right is the predominant racial/ethnic groups by census tract. So the yellow areas are predominantly Black, the blue areas are predominantly Hispanic, and then the reddish brownish area, I'm not really sure what color that is white non-Hispanic. And these areas of minority, racial and ethnic minorities overlap strongly with really good social determinants of health, like having access to mental health services, health insurance. So these bottom two maps, the first one is the reporting of frequent mental health distress, so 14 days or more of having a bad mental health day. And then the second map is the percent uninsured. So you'll see both of these are really high percent where you see predominantly Black and Hispanic racial and ethnic minorities. And I think that is all I have for my monthly updates. Any questions, comments?
Whitney, I've got a conundrum, okay? Because when I see some of these statistics, and you can only go by what you're told. We know, for example, that the medical examiner will do a toxicology report, and then he will make a determination as to what the cause of death is. And we're finding that over 90%, as much as 95% of the overdose deaths due to opioid are fentanyl. When you're gathering your data from the hospitals, do you depend on the hospital for the diagnosis as to what the overdose was? Or are you relying on the patient complaint that I did Adderall, or I did methamphetamine, or I did cocaine or cannabinoid? How do you determine in your statistics the cause of the overdose?
That's a good question. So for our overdose surveillance to determine for non-fatal specifically, fatal is a little bit easier because the medical examiner, what they determine it is what it is. We don't question that. But for non-fatal, we use a combination of, the chief complaint, what they say they took, because that's going to tell us, at least part of that is going to help us figure out where these lace drugs are. If they say, I think I took cocaine, or I was getting cocaine, but then they had a clearly clinical opioid overdose, then they might not have said it was an opioid, but we have enough evidence to include it as an opioid. So we look at the discharge diagnosis. A lot of them are unspecified, or it will just have a ICD-10 code of T50, which is poisoning by unknown substance. But if we have that ICD-10 code 50 and they say I took heroin in their chief complaint, it didn't get coded in the discharge diagnosis as an opioid overdose, but we feel comfortable making that assumption if they meet certain criteria.
Got it. Yeah, you see that.
I hate to enter in here again, and I don't mean to be.
No, that's okay, Scott. You're our.
I do have some expertise on this. What is the mechanism for determining these deaths? In other words, do we have infrastructure? Do we have the capabilities and resources for actually measuring what the cause of death is? I.e., we talk about mass spec, we talk about NMR, we talk all these analytical tools. Are we actually implementing those?
Yeah,
Or are we?
Scott,
Yes.
we do have the medical examiner and the toxicology report, which
Yes.
so for the deaths, it's a lot, as Whitney just said, it's a lot easier to make that determination because you have the physical evidence of what was, what drugs, what polysubstances were in the toxicology report. What I'm trying to figure out is how we can be as accurate as we can be on non-fatal overdoses because of a person who is taking a drug, so that would be their chief complaint, with absolutely no idea that there's fentanyl involved. We can determine that on death because fentanyl will be in the toxicology, and it does not break down either, like heroin does to morphine. So, but on the, I don't know that there's a better way to do this because the hospitals are not doing toxicology reports, tests to determine what substances they are. I mean, they may do observation and they may determine, okay, Narcan, this was responsive to Narcan and therefore it's likely an opioid. But in many cases I would submit, especially something that comes in as a complaint of cannabinoid, if somebody's in on an overdose of pot, I'm sorry, that there shouldn't be more than I mean, correct me if I'm wrong, but to the hospital on marijuana, it should be an unusual thing, but fentanyl would be the driver. So, I just bring this up. I mean, maybe we can all think about it. Whitney, maybe you can talk to your folks and see if there's something going forward that maybe questions that can be added. I don't know that there are. It's just that we have to face the reality that of the overdoses, it should be well over 80%, if not 90%, that have fentanyl involved in a polysubstance type of a complaint.
And I fully agree with you, Al. I guess the only part I'm trying to bring out here is how do we scientifically validate these opportunities for understanding what actually was the causality. I'm not sure. I'm not sure what our capabilities and resources are. That's all.
So we're, I'm bringing it up. These are excellent numbers. I have in my mind the Department of Health. There being legislation to require hospitals, because this is an epidemic here, this is an emergency, to require hospitals without having an MOU to give us the data, to give you the data, Whitney, so that you can be as accurate as you can. I mean, the fact that JFK Central is not, agreeing to participate through the MOU is, is troubling. It's just troubling because anybody who doesn't participate affects your analysis.
Yes.
Jennifer, Dr. Atenito is going through the tortures as well on the transports, because not everybody, we don't have, our data is not foolproof. So anyway, I just bring it up that I don't know that there's an answer to this, Whitney, but the more accurate we can be on the actual drugs that are driving the overdose, the better off we'll be to be able to target responses.
Absolutely. I definitely agree with all your sentiments. I mean, our biggest thing that I personally would love to see is for overdose to be pushed to a reportable condition. So right now, there's no law that says hospitals are mandated to report overdoses to the Department of Health. So all of our partnerships are very much appreciated. They've been great working with us, and we're always trying to expand our partnership to get as much of the data as possible, because we know without the data, it's really, you have to take things with a grain of salt. So we rely on our syndromic surveillance from Essence and the EMS to kind of give us the overview of what's going on, but that down to the patient level, I took cocaine, but I had an opioid overdose. Like, that's the stuff we really need to see. So aside from getting overdoses as a reportable condition, just encouraging the hospitals to test for drugs beyond the standard 5-panel, and just it's hard because I was just talking with Dr. Sneed from the medical examiner office, and they're adding, I think, 3 or 4 new NPS novel psychoactive substances that they found recently. So, you know, if we go through all this push about getting fentanyl tested and then, you know, it's come and gone and we're too late and it's moved on to another substance, they have to push for that substance to get tested for. And, you know, we just really need to be proactive as a county.
Yes, yeah, I agree. And you're doing a great job. You know,
Yeah,
one, and I'll let you chime in, John, in a second, but one thing that just popped into my mind is we have opioid dollars coming down the pike. It can't be very prohibitively expensive to, I think some of the hospitals are resisting because it's costing them money to do toxicology testing. And they're not getting reimbursed for that. And maybe it's something one of the more minor but major things that we want to look into, minor in terms of the number of dollars it would take, but major in terms of the information that it would give us. So maybe something to consider. John, go ahead.
Thanks, Al. And again, thank you, Whitney, and your team so much. You know, publicly, again, recognize how valuable this work is. We've had the chance at the county with Whitney's team and ours to meet, particularly in our current budget process and doing a deeper dive into this data as we try and, you know, advance our work at the county. So really appreciate that. First, the slides that were presented, was that a part of the attachments? Because what I'm showing is just a couple of slides as an attachment. So could we just make sure that what was presented by Whitney is circulated to us, Al?
You know, Mary Ann will get it out to everybody. It came in late, that's why it didn't come in.
Yeah, I'm sorry, I was last minute. But there's
Don't worry,
also
Whitney.
the email address. If anybody wants to sign up for our distribution list, I'll be sending out both the January and February reports tomorrow. So od2a@flhealth.gov to sign up. Or if you have any data requests or anything like that, let me know and we'll do our best to accommodate.
Yeah,
Excellent.
thank you, Whitney. And if I could just editorialize here, Al, just a bit, you know, it's almost whack-a-mole when we stay focused on the substance, you know, and you know, chronically chasing it. I think the other valuable piece to this work is exactly what Whitney's presenting around causes and conditions and incidence rates, social determinants of health, you know, and it's when we need deeper in our interventions that should not be singular in nature, but systemic in nature. I think that's where we'll see the real overcoming of this. So I think, you know, taking this data and utilizing it in ways that help inform not just singular interventions, but kind of the systemic approaches. You know, I just want us to keep that, you know, the eye on that prize.
Yeah.
Thanks.
Yeah, good point, John. Good point. Okay, Whitney, you guys do great work. Thank you again for participating and for giving us this information.
Absolutely, thank you.
The last thing on the agenda before just comments is something I did not think I would see, but Whitney Lehman, so we have the Whitneys closing out the show today. Whitney Lehman was talking to me about Yogi, and Whitney, why don't you go ahead and tell us about this program that FAR is using, or at least the individual recovery residences under the FAR umbrella are using.
Sure. Yeah, actually, only about 2 or 3 FAR certified homes are using this service. There's about 15 treatment facilities that are also subsequently certified by FAR. They're housing components that are using this service. But this is Yogi, and you'll see Sasha in the picture too. He is a hero in Palm Beach and in Broward and Dade. And so what Yogi does is Yogi goes into treatment centers and housing facilities, and he just does routine checks to make sure that individuals are not bringing in drugs to these facilities. It also deters individuals from thinking about bringing drugs when they know that dogs are going to be popping up on a regular. it's a shame that this service is not being utilized more. I mean, as you can see, this dog finds drugs in treatment centers, detox centers, residential centers that people were going to bring in and use and could potentially die from. Today, he found, just his owner texted me, he found Delta 8 gummies, but what was scary about this is inside the gummies, he found pressed blues laced with fentanyl. And this was going to be ingested by someone in a treatment facility. And so I asked Al, and I spoke to Dave about it when we were at the ribbon cutting ceremony for James Club a couple weekends ago. I think that we need to honor this dog and give this dog a Heroes Award to spotlight what he does for this community and this industry, and get the word out so that more facilities think about the use of such dogs. I mean, Yogi is phenomenal because he happens to be the most qualified dog in the state. He's certified to detect more drugs than any other canine in our state. Kratom, Kava, even just faint uses where it's a bag that just has a little bit of laced, maybe heroin or fentanyl, he'll still detect it. And so I really think that we should honor this dog so that we can get the word out and more facilities begin utilizing such service, whether it's Yogi or someone else.
Hey, I'm gonna ask Joseph, do you think Commissioner McKinley might be interested in a proclamation for Yogi? What do you think?
I think that's a possibility. I would ask that the request come officially into her email, and then we can see when that might be appropriate and for which month.
Whitney, can you put something together with some background? And you know, I'll support it through the task force will support it. Great. Maybe that can get the word out a little bit that Yogi's available. Any other ideas or any other comments on Yogi? It's frightening to think that at a treatment facility, this canine was able to find fentanyl. I mean,
It's insane that it's a daily occurrence that he finds drugs in these facilities. And so what is he not finding at the facilities that he's not going to?
Well, what about the expansion?
I'm sorry, Scott, say that again.
Oh, I said, what about expansion of Yogis?
Yeah, there are a number of dogs in the state. This particular owner owns 5 German Shepherds. 3 are in training right now. Sasha is also qualified, not as qualified as Yogi, but equally in certain substances. But there are dogs like this all over the state.
Any other comments or questions?
Yes, can I ask a question, please? It's Lori here.
Okay, Lori, go ahead, Dr. Vinnick.
Yeah, I'd just like to know if there is a website for this, because I was just looking it up, Googling it, and I see that there's a few websites for drug testing dogs, checking dogs. So is there a website for this particular Yogi?
I will find the website. I know that they have a Facebook page that they predominantly post on, and they just changed their name to DSK9 from their previous name, but I will find it and distribute it.
Thank you very much.
Awesome.
And Al, if I might chime in, I know the proprietor of this operation, Paul Tessine, very well. He's a native of Hamilton, New Jersey, my hometown. I'm very good friends with him, and Paul not only marries the skills of his German Shepherds, but is also a person in long-term recovery and an interventionist as well. So I can really attest to what Whitney just shared with us.
Awesome. Thanks, John.
Maybe one of our resources here and capabilities that would save some dollars would be to integrate further this opportunity to have these canines that would do a whole lot. Look, they are the ultimate mass spectrometers. Okay, they would save us a lot of money if we could just implement them into at least part of our armamentarium. And then, of course, go further from there, because you know I'm a scientist first. But look, I know dogs have better noses than most mass spectrometers.
Well, I don't think that we can ingrain this into a DCF licensing requirement. But, and I'll let Jennifer Williams tell me I'm wrong, but you know, that it's not kind of in their wheelhouse. But, you know, it would be helpful if
It's
every
a start.
facility, you know, if every facility had, you know, there was a spot check type of thing in facilities and recovery residences that are attached to facilities, residences. But okay, anybody else have any comments on Yogi? All right, anybody have any general comments in the task force? And then I'll open it up to the public. We are getting out of here early, like I promised. Our next
Yes.
meeting is June 1st.
Al, I
Yes,
know
Al,
I've been active today, but if I could just, from a member comment, I've just thrown in 2 links, one to Paul Tassine's Drug Sweeper Facebook page. The second, if I could announce to the group, is the Hub is hosting on April 14th, the documentary, and the producer of that documentary, the Tipping the Pain Scale, Greg Williams will be here. It'll be a great community event. Greg, if anybody knows in this space, is the producer of Anonymous People and Generation Found. So this is a third in a series of documentaries that he's produced about not only the opioid epidemic, but addiction in America as well. So if you, I really would encourage you to attend that event. The link is in the chat. Thanks, Al.
Thanks, John. Any other comments?
Yes, Al. I just have a brief announcement, and
Oh, Alton, sorry. You're
yes,
gonna,
sorry. Yeah, I have a brief announcement, and we'll be sharing a little bit more information on this in the next few weeks. But in the next month and a half or so, DAF will be opening a subtext residential unit for clinical stabilization using subtext. And the length of stay on average will be around 60 days, could go longer, depending on what the individual requires. And our goal is to use Sublocade as the continuity of care process. So once they leave the unit, we will transfer them onto Sublocade, which is the 30-day injectable, and as they go into a outpatient environment. So it'll be somewhere between 16 and 18 beds.
thank you, Alton. That's good news. Keep us posted on that, would you please?
Will do.
Any other comments? Okay, how about public? Any public comments? Now's your chance. All right, well, thank you so much. I got you out of here 45 minutes early. And we'll see you on June 1st. I'm sorry.
Hey, Al, this is Doug Simon. I didn't get a chance to introduce myself to everybody at the last meeting, but I wanted to just take 2 seconds to say who I am and what I'm doing. My name is Doug Simon, and I'm the new Director of Drug Policy for the Governor's Office. And I sat in on part of the last meeting, and I have been listening in all day. And I just want to thank everybody for all the hard work they're doing. I'm going to put my contact information into the chat if I can. I want anybody and everybody on this call to call me anytime you want. Send me an email. I return all calls and phone calls within 24 hours. And I really need, if I can, everybody's help. I have been extremely encouraged by what I've seen around the state. People are working in prevention and treatment everywhere. And There's really so much work to be done, but it's really encouraging to see the kind of the army we have out there. So thank you all. And I'm going to put my info in here, and please call, email. And if you're in Tallahassee, please just reach out. We'll sit down for as long as you want in my office here or in the governor's office, and we'll work together. So thank you.
Doug, thank you so much. I'm delighted that you were able to join in on the meeting. Nice to meet you, sir. And good luck. You've got quite a job with the 67 counties on your hands, but hopefully we'll give you some innovative stuff to bring to the rest of the state. Okay. Any other comments? With that, thank you so much for being part of the task force, and we'll see you again on June 1st. Bye now.
Bye,
Bye-bye.
everyone.
Thank you, Al.
Thank you.
Thank you, everyone. Have a great day.